Welcome back. Today we will build on to the algorithm we've been using for cognitive assessment and talk specifically about what to do if you find a patient has a positive screen for cognitive impairment. What should you consider a positive screen, and what should you do about it? These are the validated tools we have discussed and demonstrated. I encourage you to become familiar with at least the mini-cog and either the MMSE or MoCA. Remember, too, that the AD8 is for family or friends to provide information. It has been shown to be just as valid as the other cognitive assessments for possible cognitive impairment. In addition to the standardized tools, please remember that your clinical judgment is a key factor in identifying patients with significant cognitive decline. After all, who knows these patients better? Who has seen them over time? Often, it is the primary care provider who has the best vantage point to see cognitive decline. Consider these situations where clinical judgment may lead you to pursue further diagnostic assessment, no matter what the standardized assessments show. Significant change is not something that comes with aging alone, whether it's cognitive ability or personality. If you hear, "She can't hold a conversation like she used to," or "That's not the man I married," don't pass it off as aging. Keep in mind that Alzheimer's pathology strikes first and most seriously in the hippocampus, and the short-term recall ability is often the first to change. Even minor changes on recall can sometimes be the earliest symptom. An elder with a first case of depression, outside of a grieving situation, should be assessed for dementia before anything else. Same is true of an elder with an unexpected delirium postoperatively or a confusion that takes longer to clear in the postoperative setting. While it might clear up 100%, they need to be on a watch list, since that clinical occurrence can be the beginning of a persistent decline. So you have screening tools and you have your own clinical judgment. Your next decision after a screen comes positive or your clinical judgment tells you there needs to be more assessment. Your next decision is to refer or not refer. The Alzheimer's Association algorithm presents the options. You can refer the patient to a specialist, or you can manage the assessment on your own and conduct a full dementia evaluation. Today we will talk about the process of referring your patients, and in the next video we'll talk about full dementia evaluation. When you need a specialist to help your patients and families facing this type of diagnosis, if possible, you want to find someone who helps make the diagnosis and then helps the patient and family deal with the changes this type of illness brings. Depending on the specialist in your area, it might be a geriatrician, a neurologist, a geriatric psychiatrist, or a neuropsychologist. Keep in mind that sometimes academic diagnostic centers can be helpful for second opinions or more complicated cases. In addition, some areas have what are called memory disorder clinics that have a comprehensive set of services as well. In preparation for a referral, you probably want to send along any cognitive testing or AD8 that you have completed, in addition with general recent labs and any brain imaging, if you already have those. Otherwise, the specialist will probably go ahead and get their own test after their assessment. Thanks for watching. I hope you're becoming more comfortable with handling these types of complaints, either memory loss or some other cognitive complaint that a patient or a family member shares with you.